Bismillah ar-Rahman ar-Rahim. Thank you very much, dear Chairman, and thank you very much, Sanofi, for inviting me to speak on behalf of Sanofi. And I'm going to start with some treatment gaps in management of type 2 diabetes. We usually do a mistake to leave our patients for years without reaching the glycemic target. Patients usually take years to move from only one oral antidiabetic medication to the next step of 2 antidiabetic medications, then to 3 antidiabetic medications, then to add 1 injection of insulin, then to complete insulin initiation, and also even 3.7 years to add something like the new medications of GLP-1 receptor agonist. Approximately 50 to 70% of type 2 diabetic patients fail to achieve the glycemic target even 1 year after insulin initiation, and this target is less than 7%. According to the standards of medical care, the American Diabetes Association 2021, this is the consensus algorithm for injectable therapy. If hemoglobin A1C is above the target, despite double or triple therapy, then we consider an initial injectable combination. For example, GLP-1 receptor agonist plus basal insulin or branchial basal insulin, especially if hemoglobin A1C is more than 10% or 2% above the target, because no other medication will let me reach the target in these patients. And to consider a GLP-1 receptor agonist in most patients prior to insulin. يعني الكلام ده ابتدى يتقال ان انا ما ابتديش انسولين الاول، لا، ان انا لازم ادخل في مرحله ال GLP-1 receptor agonist before insulin initiation. If the patient is on GLP-1 receptor agonist or GLP-1 receptor agonist is not appropriate, then we should go to insulin. If the patient is on GLP-1 receptor agonist, we can add a basal insulin. If the patient still not controlled, to add a branchial insulin. Then to increase the number of branchial insulin injections to reach maximum 3 meals or 4 meals according to the patient's meal. Then let us back again to consider if the hemoglobin A1C is above target, 10% hemoglobin A1C or 2% above the target, we should think about GLP-1 receptor agonist or a combination with GLP-1 receptor agonist with basal insulin. The current ADA guidelines recommend the combination therapy. When to give the combination therapy? If the baseline now is 1.5 to 2% hemoglobin A1C above the target, and we are reaching the maximum combination of oral combination, then we have to shift to something more strong than the oral combination. And the combination of basal insulin and GLP-1 receptor agonist has a potent glucose lowering effect. It acts on both fasting and postprandial blood glucose with less weight gain, because we all know that when we add insulin, we're going to have more weight. The patient will put on some weight. So this weight will be reduced, weight increase will be reduced with adding the GLP-1 receptor agonist. This is the complementary actions of basal insulin and GLP-1 receptor agonist, targeting different pathophysiological defects in type 2 diabetes. For example, on the brain, we can find that the GLP-1 receptor agonists lead to decreased energy intake and increased satiety. On the pancreas, GLP-1 receptor agonists will lead to glucose-dependent insulin secretion and less glucagon secretion and less effective glucagon on the liver. On the GIT tract, GLP-1 receptor agonist will inhibit gastric emptying, will cause a sensation of fullness in the stomach, so the patient appetite will be reduced. On the liver, the basal insulin will inhibit hepatic glucose production, and also the GLP-1 receptor agonist will again inhibit the hepatic glucose production. On the adipose tissue, basal insulin will activate the insulin receptors, and the skeletal muscle with the basal insulin action will increase the glucose disposal. And we come now to the IGlarlixi, which is a combination of basal insulin, insulin glargine, together with GLP-1 receptor agonist lexinotide. And this is again the complementary mode of action of both basal insulin and GLP-1 receptor agonist, providing control of both postprandial blood glucose and fasting blood glucose. We will find that the basal insulin will reduce or control the fasting blood glucose, and the GLP-1 receptor agonist will adjust the postprandial blood glucose. So there is complementary action to both basal insulin and GLP-1 receptor agonist. We come now to some research done on IGlarlixi, the combination. And the first study is Lexilan-O study on patients uncontrolled on oral therapy, and the group of Lexilan-L and Lexilan-G studies, patients uncontrolled on basal insulin or GLP-1 receptor agonist, and let me start with the Lexilan-O. Lexilan-O, the patients are uncontrolled on oral therapy, and it is titratable fixed dose combination, IGlarlixi, versus insulin glargine. We're going to discuss, these are the arms. We have 3 arms. Those patients are type 2 diabetic patients using metformin alone, or plus a second oral anti-diabetic medication, and the hemoglobin A1C between 7 and 9% if on 2 oral anti-diabetic medication, and between 7.5 to 10% if on metformin alone. And the 3 arms are lexinotide with metformin, GLP-1 receptor agonist only with metformin, and the second arm is IGlarlixi combination with metformin, and the third arm is IGlarlixi with metformin. This is the result in hemoglobin A1C reduction, and we can find that IGlarlixi had the maximum benefit on reduction of hemoglobin A1C, where there was 1.6% reduction in hemoglobin A1C, and most of the patients could reach hemoglobin A1C of 6.5. Also, the 7 points SMBG, measuring the blood glucose at 7 points, gave good results, or the best results again was with IGlarlixi. Lexilan-O patients on oral anti-diabetic medications but not controlled, and this is the percentage of patients reaching the target of hemoglobin A1C. We can find that 74% of the patients could reach a target less than 7%, and 56% of the patients could reach the target up to less than 6.5%. The weight change, there was reduction in weight, 300 grams in patients receiving IGlarlixi, but of course the insulin arm, there was increase in weight. For hypoglycemia, it was comparable even between the IGlarlixi and the insulin glargine alone. And I come now to the other study, Lexilan L. Efficacy and safety of Lexilan, combination of GLP-1 receptor agonist lexinatide together with insulin glargine in type 2 diabetic patients inadequately controlled on basal insulin. These patients were not controlled on basal insulin. These are two arms, patients, diabetic patients receiving basal insulin and hemoglobin A1C between 7.5 to 10%, and the two arms, one of the arms took insulin glargine plus or minus metformin, and the other arm took insulin glargine combination with lexinatide, IGlarlixi. And this is the reduction in hemoglobin A1C by the end of 30 weeks. Hemoglobin A1C in the group of IGlarlixi was reduced to 6.9 compared to 7.5 in the group receiving only insulin glargine. Again, those are the percentages of patients reaching the target. Patient reaching the target less than 7% was higher. It was 54% in patients taking IGlarlixi compared to 29% in patients using only insulin glargine. And for patients less than 6.5, again, it was higher percentage, 33% of patients versus 14% of patients using insulin glargine. The weight change, of course, there was reduction of weight, 700 grams in patients receiving the combination, and those who were on only basal insulin, the weight was increased 700 grams. Hypoglycemia was less in the group received the combination, the IGlarlixi. Let me introduce the pens to you. We have two pens of IGlarlixi, the peach and the olive pen, and the peach pen starts with insulin glargine, dose of 10 units, and each 10 units will be accompanied with 5 microgram of lexinatide. So this pen is with a ratio of 2 to 1, 2 insulin to 1 lexinatide. And the starting dose is 10 units insulin glargine, and the end of this pen, آخر حاجة فيه, is 40 units. To be compared to the olive pen is called Soliqua 3060 pen, starting with 30 units of insulin glargine, and the 30 units of insulin glargine will be accompanied with 10 microgram of lexinatide. So the ratio in this pen is 3 to 1. And this is how to use the IGlarlixi. If the patient is insulin naive, then we will start with 10 units of the peach pen. If there is a previous basal insulin dose less than 30, then to start with the peach with 20 units. If the previous insulin, basal insulin, is more than 30 basal insulin, then we should start with 30 insulin glargine, and there's going to be 10 microgram lexinatide. We will show it again by the end of the study. Let me introduce to you this study, published study in different places, and this study is the real-world safety and effectiveness of IGlarlixi in people with type 2 diabetes who fasted during Ramadan, because we have our patients fast during Ramadan and also they fast many days around the year. So we should know how to deal with these patients. And I was honored to be one of the co-authors together with my dear colleagues, the principal author and principal investigator, Professor Muhammad Hassani. This is called the Soliram trial, and the patients were given lexinatide combination with insulin glargine, the IGlarlixi, 1 to 3 months before Ramadan, and the holy months of Ramadan, and 1 month after Ramadan. And during Ramadan, pre-Ramadan and after Ramadan period, there was no change in dose, or the minimal change of dose between before Ramadan and after Ramadan in IGlarlixi. Also, 71% of people used IGlarlixi during pre-Ramadan period. More than 40% of people were injected during breakfast, because some of the patients prefer to take the medication in another time of this period of Ramadan fasting. And for the safety data, for pre-Ramadan, the incidence of hypoglycemia was 1.3%, which is minimal incidence of hypoglycemia, because we are in Ramadan and we are using insulin. And during Ramadan, 2% only of patients suffered from hypoglycemia. So hypoglycemia incidence were low using IGlarlixi. The efficacy, the hemoglobin A1C was reduced post-Ramadan from 8.3 to 7.5%. And also the fasting blood glucose was reduced. And the body weight was less before post-Ramadan compared to before Ramadan. And the conclusion of Soliram trial, patients with type 2 diabetes participated in Soliram trial wave 1, treated with IGlarlixi combination. They were able to fast for most of the months, most days of Ramadan months, and the incidence of hypoglycemia was low, and glycemic control was improved in this real-world setting. Now I come to a very important trial. It is a recent trial, which is the Solimix trial, comparing IGlarlixi versus mixed insulin, and this mixed insulin is biphasic insulin aspart 30 in patients treated with basal insulin, and these patients, of course, are type 2 diabetic patients. Patients were adults, uncontrolled type 2 diabetic patients, in spite of the treatment with basal insulin with 1 or 2 oral anti-diabetic medication. And hemoglobin A1C was more than 7.5, and from 7.5 to 10% hemoglobin A1C. And there was 2 arms, either IGlarlixi once daily or biphasic insulin aspart 30 twice daily. It was a multicentric trial, 26 weeks randomized trial, phase 3B study, comparing safety and efficacy of both types of diabetes management. The Solimix trial, there was primary safety endpoints, non-inferiority of IGlarlixi to biphasic aspart insulin, and hemoglobin A1C reduction by the end of 26 weeks, and superiority of IGlarlixi in body weight change from baseline to week 26. There was key secondary points, superiority of IGlarlixi versus biphasic insulin aspart, glycemic control without weight gain or hypoglycemia, hemoglobin A1C reduction, and the safety endpoints were hypoglycemia, any hypoglycemic event, or AGA level 1 hypoglycemia, AGA level 2 hypoglycemia with blood glucose less than 54 milligram per deciliter, or AGA level 3, which is severe hypoglycemia. Solimix trial showed non-inferiority of hemoglobin A1C change and superior body weight change from baseline at week 26 of the trial with IGlarlixi. IGlarlixi was superior in baseline hemoglobin A1C reduction, and also less weight. Weight was reduced, as we can see here, 700 grams, compared to increased weight 1.2 kilograms in those received the biphasic insulin aspart. For patients reaching less than 7%, the IGlarlixi was better efficacy. 42% could reach this target, and for patients reaching less than 7% without weight gain, 27% of cases, and patients reaching less than 7% without weight gain and without hypoglycemia, 19% compared to 7% in mixed insulin. The non-inferior reduction in hemoglobin A1C observed with insulin, with IGlarlixi versus biphasic insulin aspart was associated with a smaller mean daily insulin dose. The insulin dose, as we can see in the right side, at week 26 was 40 units in insulin glargine combination with IGlar, which is IGlarlixi, insulin glargine with lixisenatide, compared to the biphasic insulin dose by week 26, it was 58 units. Then 18 units different between the combination of GLP-1 with insulin glargine compared to biphasic insulin. There was low risk of hypoglycemia at week 26, whether the incidence of level 1 hypoglycemia, the incidence of level 2 hypoglycemia. There was no severe hypoglycemia in this trial, and hypoglycemia was reduced 45% and 55% in the group with IGlarlixi than the biphasic insulin. This, of course, favoring the use of IGlarlixi. Again, this was the event rate. It was reduced in IGlarlixi, whether level 1 hypoglycemia or level 2 hypoglycemia. Let me again revise the pens. We have those two pens, the peach pen, called 10 to 40 pen, 10 to 40, which is the insulin dose given to the patient with 2 units of insulin to each 1 microgram of GLP-1 receptor agonist lixisenatide. In the olive pen, it is called 30 to 60. 30 units of insulin is the minimum dose of insulin given to the patient, and 60 units of insulin glargine is the maximum unit given to the patient, with a percentage of 3 to 1 insulin, 3 units to 1 microgram of lixisenatide. For insulin naive patient, starting dose is 10 units of insulin together with 5 microgram of lixisenatide, and then if the patient is switching from less than 30 units insulin, basal insulin, we start with 20 units of basal insulin, and there is going to be 10 units of lexinotide in this dose. And then 20 units. And when we switch from basal insulin more than 30 units, we use the olive pen, and the starting dose is 30 units. And we can go higher up to 60 units of basal insulin. And don't tell me why shouldn't we increase the insulin, the basal insulin dose, because it's not recommended, and the AGA recently mentioned the term over basalization, when we shouldn't give basal insulin more than this. Thank you very much.
Thank you, Professor Inass Shaltout, for this great lecture summarizing the IGlarlixi trip. طبعا بشكر حضرتك على الدعوة للمؤتمر وبشكر شركة سنوفي و it's a great honor to co-chair this with my professor Professor Farid Fawzi. Any questions from the floor? Yes, question here, Mike, please.
Thanks, Dr. Inass, for this lecture. I want to ask about in naive patients for the first time insulin, you said that we will start with 10 units. If the patient is hemoglobin A1C more than 10 and fasting more than 300, also we start with 10 units only?
When we start with 10 units basal insulin, this is again the advice of using the basal insulin, is to start with 10 units insulin. But the upgrading, the titration is like the titration of the basal insulin. We measure the fasting daily, and we can increase the dose every day even. So we can reach the minimum dose required, not the maximum dose required. We can just titrate 1 or 2 units every day according to the fasting blood glucose to reach the dose which is tolerable by the patient. When we start with lexinotide 5 microgram, this is a benefit that the patient will tolerate the drug more than using higher doses. Because we know that GLP-1 receptor agonists have some gastrointestinal side effects. So when we start with 5 and up titrate within a week or so, the patient will not suffer any GIT side effects.
Thank you, Dr. Inass, for this nice presentation. We didn't see, could we consider that combination in comparison to bivasic insulin while reducing the doses? So, for example, bivasic insulin, we usually use 2 doses. Why it's not considered as a benefit that you decrease? Why it's not considered as a benefit? So instead, patient inject himself 2 times, he will inject only 1 injection. So the number of the injection, why it's not considered as one of the benefits of this medication?
This is a benefit from the beginning, that you're giving a combination of 2 medications in 1 injection. So this is a benefit from the beginning. But this study was to show if there is superiority, for example, of premixed insulin or not. And it showed no superiority. It showed that IGlarlixi is superior to the mixed insulin.
No, I mean, this is a point in favoring of the the combination of glargine with the
Yes, sure,
lixisenatide.
sure.
So why it's not considered as
Because this is the way to give the combination. It's only one daily. There was studies done by, I think, other pharma companies making GLP-1 receptor agonist, and they found that if the patient has less injection, it's going to be more tolerated by the patient, and patient will accept the medication more easily. So this is known. This was not the objective of the trial, because you compare between once daily injection and twice daily injection. It's a benefit. Of course, it's a benefit. But is it a benefit without added benefit of superiority in effect? No. In this study, Solimix showed superiority even in effect.
so I mean it's an indirect effect if you study the adherence between the two, the difference in
Do you
adherence
have
between
any
the two.
studies on adherence of, or in this trial, was there any comparison in adherence of medication between the twice daily mixed insulin versus the once daily IGlarlixi?
in favor of الIGlarlixi versus Premixed، ودي كانت نقطة تاكلد. بس زي ما حضرتك كنت بتقولي يا دكتور إيناس، هي ما كانتش primary objective أو primary endpoint، لكن echoing your words على الستاديز الكتير اللي اتعملت على الادهرنس للعيانين according للنمبر اوف injections. طبعا كل النتائج كانت بتطلع ان كل ما عدد الانجكشنز بيقل كل ما الادهرنس بيزيد، وده بيبقى ريفلكتد اوف كورس على الجلايسيميك كنترول. فده طبعا زي ما الدكتوره بتقول هو ده شيء مفروغ من امره جدا وادد بنفيت طبعا، لكن زي ما حضرتك دكتوره ايناس ان الاول انا بقيس الافيكاسي، لان انا مش هعمل حاجه سواء ويت تشينج سواء ادهرنس اون ذا اكسبنس اوف الهيموجلوبين A1C نفسه. اي هوب ان يكون
يعني الافكسي هو اهم حاجه. فانت عايزه اقول لحضرتك استخدام البيزل انسولين حتى بالنسبه للبيشنتس سهل قوي على البيشنت لما بيجي لك باخد 2 or 3 oral and is not controlled، ان انت تقولي له طب هي شكه واحده في اليوم بس، بيأكسبت الشكه في اليوم. فلو انت هتدي له شكه واحده في اليوم بس 2 medications، وبعدين تقدري كمان في الحاله دي ان انت تزودي oral ليهم another action، فيعني تبقي بتستفيدي بان 2 في 1.
This is in comparison with the novo medication products. They are studied the adherence of the combination between the insulin and the liraglutide. If you give it in combination, it's found to be the patient are more adherent than to give it just alone. Thank you.
Thank you.
شكرا.
Thank you very much.
شكرا دكتوره ايناس. اخر سؤال معلش.
في سؤال يا دكتور انس لحضرتك. في سؤال.
Thanks for elegant presentation as usual. سؤالي عن السويتش. سويتش يعني 2 occasions. سويتش عيان بياخد بريميكسد انسولين. بريميكسد انسولين مرتين. لو انا حضرتك سوليميكس او الجالريكسي كانوا بيتكلموا عن العيان بياخد بيزل بس، طب عيان بياخد ميكسد هقلب ازاي بنفس الطريقه ولا في موديفيكيشن؟ السؤال الثاني لو عيان بياخد بيزل بولس، لو عيان بياخد بيزل بولس هتعامل معاه ازاي؟ هقف الاثنين بولس وهخلي واحد بس ولا ايه الحل؟
بص هو برضو قرار بقى ان انت تقلب بيشنت بياخد many insulin injections per day ان انت تغيره على one daily insulin. لازم تبقى شايف ان البيشنت ده ينفع الاول حقيقي. يعني معلش انا ماليش دعوه طبعا بالستادي ما بينتش الكلام ده، لكن لو كان عندك بيشنت ديبندنت على الانسولين وبياخد basal bolus وهو معتمد على كده، ده as if this patient is starting to be type 1 not type 2. فيعني لازم برضو تفكر 100 مره قبل ما تقول له طب انا هلغي لك ده وهبتدي ادي لك 1 daily injection. انت قصدك
لا.
بيزل بولس؟
انا قصدي بيزل تايب 2 خلاص دي مفروض
آه.
منه تايب 2 على بيزل بولس كان واصل
1 دوز
بولس 3
آه.
تمام. انا هقفله.
اسمها بيزل بلس لان بيزل بولس معناها ان انت هتدي مع كل وجبه.
ايوه ده اللي انا اقصده.
ما انا بقول لك انت دلوقتي عشان تاخد قرار ان انت تنقل بيزل بولس، واحد بياخد 4 مرات انسولين في اليوم، تقول له لا انا هدي لك مره واحده بيزل مع الايجلارليكسي.
ما اقصدش ده. انا هدي ايجلاريكسي بالاسم بتاعه وهدي 2 برانديال انسولين عادي. انا هدي مثلا ايجلاريكسي مع المين ميل وهدي برانديال مع التوميز.
حسب ما انا اعرف ان this is not a recommendation مش كده؟
يعني هي دي
إن إحنا
يعني تخيل بعيد قوي.
ايجلارليكسي ودي مع ايه؟ نتناقش بعد كده.
كنت اقول يعني ده تخيل بعيد قوي يا دكتور. يعني لو هو محتاج بيزل بولس غالبا مش هيستجيب، يعني هيبقى ما فيش دور للجي ال بي 1 لان في الحاله دي هيبقى يعني البيتا سيل ريزيرف از فيري لو، وبالتالي الريسبونس للجي ال بي 1 ريسبتور اجونست مش هيبقى ماكسيمم او مش هيبقى اوبتيمال. ففي الحاله دي يو شيفت توتالي تو بيزل بولس. لكن ما فيش ميكس ما بين الميكس ده اللي هو الايجلارليكسي او يعني البيزل مع جي ال بي 1 بلس 2 برانديال دوزس، لا يعني ده تخيل بعيد قوي.
طب هقول لحضرتك
الحاله هقول لحضرتك بس على حاجه. هو يعني كل الموضوع التايب 2 دايبيتس مانجمنت كله بيبقى فيه انديفيدواليزيشن وجادجمنت. يعني حضرتك لو انت في عيان كل الجايد لاينز بتتكلم على الاسكاليشن اوف ثيرابي، يعني انك تصعد العلاج اورال وبعدين اكتر من اورال وبعدين انجكشن وبعدين اكتر من انجكشن وهكذا. ما حدش ابدا بيتكلم في الجايد لاينز على الريفيرس باث واي، انك تعمل دي اسكاليشن للتريتمنت، يعني ازاي تنزل من البيزل بولس الى ليس اجريسيف ثيرابي. بس انت يو كان دو ذات. يعني انت لو انت حاسس ان العيان ماشي على بيزل بولس وما بياخدش جرعات عاليه من البرانديال انسولين وعندك الجادجمنت ان البيتا سيل ريزيرف عنده كويسه وانه ممكن يستجيب للجي ال بي 1 مع بيزل، في الحاله دي يو شيفت، لان ده هيبقى سمبليفيكيشن للريجيمن، والسمبليفيكيشن للريجيمن فور ذا بينيفيت اوف ذا بيشنت وفور ذا ادهيرنس فور ثيرابي. في الحاله دي يو شيفت. لكن انك عامل الميكس ده يعني غالبا it will not work.
هو حاجه دكتور فايده تسمح لي بس هو عاده تايب 2 المفروض ان هو البيزل انسولين بتاعه بيكون لو هو ماشي حتى على بيزل بولس بيكون البيزل انسولين بتاعه اكتر من 50% تقريبا من الديلي ريكويرمنت. لو لقيت ده مش موجود والعين كنترول، يعني زي مثلا العين بياخد 30 يونت وات ايفر البيزل انسولين و60 يونت برانديال انسولين متوزعين، ده غالبا مش هينفع هنا خالص، لان واضح ان مفيش فيه بيتا سيل ريزيرف خالص، وغالبا لو شفنا السي بيبتايد هنلاقيها في الارض مش موجوده. انما عيان مثلا بياخد 70 يونت او بلاش 70، بياخد 50 يونت بيزل انسولين و30 يونت برانديال متوزعين، ده اللي ممكن نفكر فيه ان احنا ممكن نعمله. فهو ده خلاصه الموضوع. يعني انا بس دكتور انيس كنت عايز اسال حضرتك في السوليرام، يعني هو لو هو ادينا السوليكوا نفسه ساعه السحور مثلا، يعني انا كنت اعتقد ان انا شخصيا حتى في رمضان اللي فات كنت بدي دايما قبل الفطار بنص ساعه، فعشان حاجتين، عشان البيزل انسولين يعني يخلص قرب العصر ففرصه الهايبوجلايسيميا تقل، والليكزيناتايد اللي موجود يبقى شغال فتره الست ساعات دول. فانا مش عارف لو هو كان هل في الناس دول كان في ناس خدوا وقت السحور مثلا؟
هي الفكره ان دي كانت ريل وورلد ستادي، فهم كانوا بيسيبوا كل دكتور يعالج العيانين بطريقته، فحتى كان في ناس اكتشفوا بعد الترايل ان في ناس اخذتها في خلال الصيام، اخذتها الصبح. لكن 40% of the patients اخذوها مع الافطار. فيعني قصدي ان دي كانت ريل وورلد، ما كانش فيها ريكومنديشن ان ايه انت لازم تدي بالطريقه الفلانيه. انا بس هرجع رد حضرتك على الكلام بتاع الدكتور فريد. احنا هنا قلنا الجايد لاينز ماشيه ازاي، ما قلناش العكس. يعني قلنا ان انت بتبتدي بعد الاورال بتدي الانسولين جلارجين، بتدي الجي ال بي 1 او الفيكسد ريشيو كومباينيشن او الكومباينيشن اوف جلارجين with ليكسيناتايد او يعني بيزل انسولين with ليكسيناتايد. بعد كده بقى دخلت لو مش مظبوط هتبتدي تبقى خلاص بيزل انسولين وتزود عليه. فيعني دي خطوه في النص، ما هياش هنزل وبعدين ارجع عليهم تاني.
هو كان الدكتور فريد ذكر حاجه وده موجوده في اخر سنتين في الاي دي اي، السمبليفيكيشن بتاعه الانسولين ريجيمنت زي ما حضرتك
لو
اتكلمت
الدوز
على
صغيره زي ما الدكتور غازي بيقول، يعني انت لو لقيت في عيان مثلا بيبقى سمين قوي في الاول وبتاعه فالانسولين ريكوايرمنتس تبقى كتيره قوي، بعدين يبتدي يظبط نفسه ويبتدي يخس، يجي لك بقى بدوز الصغيره قوي زي ما الدكتور حسام قال، تقوم انت تقول هو انت بتاخد انسولين ليه؟ هو ده العيان اللي انت تفكر فيه، انت ليه بتاخد بيزل بولس؟ فده اللي انت تقول طب ما انا اجرب اشيل بيزل بولس، طب ودي ميتفورمين وازود الميتفورمين وهكذا، طب ادي معاه SGLT2 واخلي العيان ياخد 1 دوز اوف ايجلارليكسي.
هو كان سؤالي بقى ازاي هعمل سويتش، هو ده كان السؤال، بس السؤال طبعا
ما هو
متاخد
ده
في حتة
على
تانية خالص.
حسب البيشنت، لان ده ملهوش ريكومنديشن، ده على حسب البيشنت بتاعك اللي انت شايفه. ممكن تبتدي بنفس البيزل دوز مثلا، يعني ممكن البيزل نفسها تتحول الى نفس الدوز مثلا، بس ده يعني عباره عن تailoring medication، يعني ده مش في الجايد لاينز. انا مش عايزه اعطل
وده
حضرتك.
ممكن يخلينا نسال سنوفي سؤال. اللايسنس بتاع الكومبينيشن ثيرابي، اللايسنس do you use it for patients who are failing to reach the target on maximum dose of basal insulin او GLP-1 alone؟ اللايسنس انا بتكلم على الريجولاتوري بوينت مش الكلينيكال بوينت.
ميرسي دكتور فريد على السؤال. احنا من الاكسلان بروجرام اللي الدكتوره ايناس عرضته اكشلي هو اتعمل على 3 patient profiles اللي هم اللي كانوا مذكورين على في الاي دي اي، سواء patients كانوا uncontrolled على oral medications، patients كانوا uncontrolled على GLP-1 كانهم start بالستيب وايز بتاع الاي دي اي guidelines، او patients كانوا uncontrolled على basal insulin. الثلاثه دول كانوا تاكلد في الاكسلان بروجرام، سواء في الاكسلان او ال او جي اللي هي اتعملت على patients uncontrolled على GLP-1 alone، والاكسلان ال كانت على patients
انا
uncontrolled
study. انا عارف تفاصيل
من دول
الاو والال والجي وكل التفاصيل، بس الريجولاتوري اوثوريتي اللايسنس بتاع الدواء does it state that you use combination of GLP-1 basal insulin in cases of 1-2؟
yes. انا بستخدمه على لو patient uncontrolled على البيزل على GLP-1 in combination with formal and formal يعني authorization مع الميتفورمين of course والSGLT2. طيب احنا في اخر يعني في الترايل اللي دكتور ايناس عرضتها في الاكسلان ال اللي
طب خليني معلش خليني اخلي السؤال
مش انا يمكن مش فاهمه مش
ابسط. خليني اخلي السؤال ابسط. احنا كلنا ممكن نبتدي بيه افتر فيلير اوف اورال ثيرابي، ممكن الانسولين نايب او الانجكشن نايب بيشنت، لكن هل اللايسنس بتقول كده انك انت ممكن تبتدي بيه في حاله الفيلير اوف مالتيبل اورال ثيرابي؟
اوف كورس السلايد اللي كانت الدكتوره ايناس عرضتها التو بنز كان فيها if the patient is insulin naive then start by 10 minutes as if you are starting a basal insulin. فالبيشنت ده
الاستادي واضحه جدا. انا بتكلم على الاف دي ابروفال او الام ابروفال. does it state that you can start it in case of failure on maximum oral therapy?
Yes.
Thank you.
Thank you.
نشكر الدكتور إناس على المحاضرة ديت.